أقلبه بهذا. بس أنت
تمشي
هذا خاف يعلس. بس أنت يمكن هذا عالي على شوي. السلام عليكم. My presentation today is on simplified basic for DALK. First, I would like to make a general review of types of keratoplasty. We have penetrating keratoplasty, lamellar keratoplasty, which is anterior lamellar, and deep anterior lamellar keratoplasty, which is called DALK. Posterior lamellar keratoplasty, endothelial keratoplasty. Deep lamellar endothelial keratoplasty, which is DILEK, decimal stripping endothelial keratoplasty, DISEC, decimal stripping automated endothelial keratoplasty. Here the difference is the graft is prepared with keratom. And also decimal membrane endothelial keratoplasty, which is called DIMIC. This is a case of penetrating keratoplasty. This is a keratoplasty for advanced keratoconus. Disadvantage of penetrating keratoplasty: we have compromised globe integrity, higher chances of graft rejection and failure, which is the main complication, secondary glaucoma, longer visual rehabilitation, early cataractogenesis if the patient is phakic, and infection. This is a complication of penetrating keratoplasty, suture-related endophthalmitis, and the other slides show expulsive hemorrhage from trivial trauma. Now, what is DALK? DALK, it is a selective transplantation of the stroma without the endothelium, originated 150 years ago with the pioneer work of von Hippel and Filatrov. There are several indications under the heading of tectonic, optical, and therapeutic. Tectonic, like dysmatocele; optical, keratoconus, dystrophy, ectasia, scar; therapeutic, like perforation, dermoid infection. Contraindications: here, to do DALK, we should have a healthy endothelium and decimal membrane. Advantages of DALK over penetrating keratoplasty: here we have less chance of rejection, longer graft survival, better globe integrity, and faster visual rehabilitation. The basic steps: partial marking, partial trephination, superficial lamellar dissection, formation of the big bubble, which is the main step here, blunt stromal dissection to the bare decimen, donor tissue deciment removal, then graft apposition. Complications: the main complication during surgery is the decimal membrane perforation, and that's mean the end of the surgery. Post-operative pseudo-anterior chamber formation, interface haze, keratitis, pupil block, and pupil sphincter damage. Here in this video, I would like to talk about the main step, which is the big bubble. As we know, deep anterior lamellar keratoplasty is the best technique for corneal transplantation when the host endothelium is quite healthy. There are several approaches to reach the decimal level dissection, the level that most of us would like to reach to get the best visual result. But the most commonly worldwide used technique is the big bubble. When this technique is enhanced of the most experienced corneal surgeon, but at the same time it fails in reaching this level. To deal with that, there are a number of strategies which try to make it easier. One of them I will talk about in this video, how to get benefit from microbubbles and convert it to a large bubble. When this strategy, it has several advantages which are connecting to the patient on the surgery, but at the same time it has its limitation because viewing of the microbubbles is not so easy. Any help?
Thank you, Dr. Nadia, for this nice presentation. The speaker, please, Dr. Amna, Dr. Nadia, Dr. Ahmed.